Welcome to Week 10 Module 7, Bipolar and Related Disorders. We are almost done with the semester. As usual, I always recommend downloading your study guide and focusing on the concepts mentioned in the study guide. In this module, we will focus on bipolar epidemiology, types of bipolar, and their treatments, especially using lithium and mood stabilizers with a long-term residual period. Nevertheless, there is no permanent cure for bipolar. Without much ado, grab a cup of coffee or your favorite water label, and let's jump into it. When you hear the word bipolar, what comes to mind? For many people, they think of mood swings or manic episodes. Well, you guessed it right. Clients who are diagnosed with bipolar disorders usually present with mood swings, depressive symptoms, and mania, also known as extreme euphoria. Research has shown that clients with bipolar may have a higher risk for mania in the summer and spring, the highest rates of depressive symptoms in winter and fall, and the lowest symptoms in summer. Some researchers blame the change in seasons from light to darker months or simply the changes in an individual circadian rhythm. Let's look at the epidemiology of bipolar disorder. You will find epidemiology information on slide number 3, and it is the first concept to remember from your study guide. In the United States, bipolar disorder affects 4.4% of American adults. Contrary to some popular beliefs that women experience higher rates of bipolar than men, the incidence is roughly equal for both genders. The onset is usually at age 25. And please note that bipolar is more prevalent in people with higher socioeconomic status. Bipolar disorder is treatable by adhering to medications and therapy. Mood and effect revisited. Recall in Chapter 25, we discussed that a change in mood can lead to how we perceive the world with depression, joy, anxiety, anger, etc. Affect is an external or observable emotional reaction to our experience. So, what are the common behaviors in bipolar disorder? Clients with bipolar disorder have manic episodes or mania, which is referred to as an abnormal mood state of elation. They feel like they are in high spirits, they have feelings of extreme joy. So, they may require hospitalization or close supervision like one-to-one. Mania period usually lasts for 7 days. On the other hand, hypomanic symptoms usually last for 4 days. Clients with hypomania have less severe mania with 3 or 4 manic symptoms. They usually do not require hospitalization. However, note that hypomania can eventually progress to mania. One of the phases in which clients with bipolar disorder are at high risk for harm is the acute phase. This phase is characterized by acute mania. Clients can harm themselves or other people. It is time to consider hospitalization or one-to-one close supervision to keep the client and others safe. Some important behaviors or symptoms to remember are grandiosity, hyperactivity, racing thoughts, flight of ideas, speech incoherence or accelerated speech, and agitation. They can engage in risky behaviors, including self-harm. Now, let us delve into the types of bipolar disorder. We already discussed manic and hypomanic symptoms. Excellent job if you were able to link the manic episodes with bipolar 1 and hypomanic symptoms with bipolar 2. Bipolar 1 clients usually have 1 or more manic symptoms and may have depressive symptoms. Here is a visual of the symptoms that clients with bipolar mania experience. They feel like they have an increased sense of power, self-worth, and more energy to the extent that they have no urge to sleep. They are talkative, easily distracted, and set goals they are unlikely to achieve. They obviously engage in risky behaviors and have delusional feelings of grandiosity compared to other people. On the other hand, bipolar 2 clients can either have current symptoms of depression, depression history, or hypomania. Please note that their symptoms are mild, not full-blown episodes or not severe enough as manic episodes found in bipolar 1. Even when they have mania, it is temporary, up to 4 days, that they do need to go to the hospital and don't have an impairment in occupational functioning. Please also note that clients with bipolar 2 can attend group therapy as long as they are stable, usually in the outpatient setting. They also do not need to be restrained. Some depressive symptoms experienced by clients with bipolar are similar to the symptoms we covered in a major depressive disorder. They include anhedonia or lack of pleasure or interest in activities they used to enjoy, appetite changes, anergia or lack of energy, flat affect, and possible suicidal ideation, among other symptoms. They have self-destructive behaviors, unable to focus, and may also appear sluggish with psychomotor retardation. Here is a visual for both manic and depressive symptoms in clients with bipolar disorder. Please note that they affect their mood, speech, sleep, weight, and attention span. Their interest in pleasure is decreased, and some of them have decreased libido. They often engage in high-risk behaviors. It is crucial to note that clients with bipolar need constant care and treatment. If they comply with medications and other treatment options, such as psychotherapy, they eventually reach a remission stage, known as the continuation phase. During this time, they experience remission of their symptoms. Compliance within 4 to 9 months helps prevent relapse. Most clients with bipolar are able to function, both personally and socially, as they adhere to treatment throughout their lives. This is known as the maintenance phase. Such treatment prevents the recurrence of manic episodes. Here is another visual, comparing bipolar 1 and bipolar 2. You will notice that clients with bipolar 1 have manic symptoms that interfere with personal and social functioning on a daily basis. They experience much energy during this period. On the other hand, clients with bipolar 2 have symptoms that are shorter and less intense. Their mood is slightly elevated during hypomanic episodes, but not as highly elevated as clients with bipolar 1. One more type of bipolar we will cover is cyclothymic disorder. I hope you remember dysthymia, or persistent depressive disorder. Cyclothymia is a similar disorder but for bipolar, which is a long-term condition, also known as bipolar 3 disorder. Clients with cyclothymic disorder have chronic mood disturbance for at least years. Please note that their manic or depressive disorders have insufficient severity or duration to meet the criteria for a major depressive disorder, bipolar 1 or bipolar 2. Nevertheless, they are never without symptoms for more than 2 months or no gap in symptoms longer than 2 months. This is a visual for cyclothymic disorder. Clients with this disorder have normal phases in which they have no depression or hypomania and occasionally have brief depressive states and then mild hypomania. Such clients can be stable by taking lithium, which is the mainstay and the most effective mood stabilizer for bipolar disorders. The last type of bipolar we will review is the substance medication-induced bipolar disorder on slide number 18. Something very important to remember about this type of bipolar is what sets it apart from other bipolar disorders. And you guessed it right, it is the fact that their mood swings or mood disturbance is directly caused by abusing a substance. Clients may present with intoxication from using substances including meth, cocaine, alcohol, sedatives, opioids, or even anxiolytics. Clients with substance-induced bipolar disorder usually experience symptoms such as irritable or elevated mood with inflated self-esteem, distractibility, insomnia, and distress during withdrawal from abusing the above substances. Please note that during your nursing assessment, you will be able to visualize some cues as these clients appear malnourished or even disheveled. What are the predisposing factors? According to psychosocial theories, clients with bipolar may have chemical imbalances. However, the etiology remains unclear. Some chemical imbalances mentioned are a decrease in GABA and serotonin, and an increase in dopamine and norepinephrine. However, these neurotransmitters may fluctuate. For example, when they experience depressive symptoms. We always recommend using the transactional model as we consider interactions between many factors, which might be biological or genetic etiologies, past experience and current conditions, and of course, psychosocial factors. I encourage you to familiarize yourself with different stages of bipolar, which we previously discussed from stage 1, hypomania. At this stage, the disturbance is not sufficiently severe to cause marked impairment in social or occupational functioning. The mood of a hypomanic person is cheerful and expansive. An underlying ability surfaces rapidly when the person's wishes and desires go unfulfilled. Perceptions of the self include ideas of great worth and ability. Thinking is flighty, with a rapid flow of ideas. Perception of the environment is heightened, but the individual is so easily distracted by irrelevant stimuli and goal activities are difficult. Hypomanic individuals exhibit increased motor activity. They are perceived as being extroverted and sociable, but they lack the depth of personality and warmth to formulate close friendships. They talk and laugh a great deal, usually very loudly and often inappropriately. Stage 2 is acute mania. Symptoms of acute mania may be a progression in intensification of those experienced in hypomania, or they may be manifested directly. Most individuals experience marked impairment in functioning and require hospitalization. Acute mania is characterized by euphoria. The person appears to be on a continuous high, but mood is always subject to frequent variation. Cognition and perception become fragmented and often psychotic in acute mania. Accelerated thinking proceeds to racing thoughts, overconnection of ideas, and rapid, abrupt movement from one thought to another and manifested by a continuous flow of accelerated, pressured speech to the point where trying to converse with this individual may be extremely difficult. Attention can be diverted by even the smallest of stimuli. Hallucinations and delusions are common. Stage 3, or delirious mania. Stage 3 is more severe form of acute mania, as clients may have panic-level anxiety, are unable to focus, and have incoherent speech. If they do not receive intervention, they could even die. It is characterized by severe clouding of consciousness and an intensification of symptoms associated with acute mania. The mood of the delirious person is very labile. He or she may exhibit feelings of despair, quickly converting to unrestrained merriment and ecstasy, or becoming irritable or totally indifferent to the environment. Cognition and perception are characterized by a clouding of consciousness, with accompanying confusion, disorientation, and sometimes stupor. Other common manifestations include religiosity, delusions of grandeur or persecution, and auditory or visual hallucinations. The individual is extremely distractible and incoherent. Psychomotor activity is frenzied and characterized by agitated, purposeless movements. The safety of these individuals is at stake unless this activity is curtailed. Exhaustion, injury to self or others, and eventually death, could occur without intervention. Before we look at the medications for clients who present with bipolar disorders, let us discuss some nursing interventions and clients' outcomes. For nursing interventions, please note that it is important for bipolar 1 to prioritize one-to-one as they are at risk for self-harm, finger foods, and a quiet environment. Remove all harmful objects they can use to harm themselves. Set clear limits as they tend to be manipulative. When it comes to group therapy, it is not ideal for clients with bipolar 1 to go to group therapy, especially while in manic episodes. On the other hand, bipolar 2 patients can attend therapy groups. Clients with bipolar can attend therapies after manic episodes when it is safe to do so. It is essential to adhere to medications and other treatment options. Sleeping is crucial because they spend most energy when they are hypermanic. Though there is no cure for bipolar disorder, the treatment will help to minimize symptoms. Clients would also engage in adaptive coping strategies. For cyclothymic disorder, please note that this requires long-term maintenance. Do focus on long-term outcomes, such as having no evidence of physical agitation, able to eat a well-balanced diet, fall asleep as soon as they go to bed, and not continuously wake up in the middle of the night even due to mild bipolar symptoms. The ultimate objectives in working with families of patients with mood disorder are to resolve the symptoms and initiate or restore adaptive family functioning. Some studies with bipolar disorder have shown that behavioral family treatment combined with medication substantially reduces relapse rate compared with medication therapy alone. Our focus is on lithium carbonate, which has been a drug of choice for many years. Antidepressants are also used when clients have depressive symptoms. In recent years, a number of investigators and clinicians in practice have achieved satisfactory results with several other medications, including anticonvulsant drugs, which have a mood-stabilizing effect either alone or in combination with lithium. Patients who respond to lithium can virtually be symptom-free over the long term, and about 33% of people treated with lithium respond positively. Lithium can be taken alone or combined with mood stabilizers. Please recall lithium levels 0.6 to 1.2, normal levels for maintenance, and up to 1.5 for manic behavior. Lithium levels are usually checked once a week when hospitalized and every 1 to 3 months when stable, usually in a home environment or a halfway house. It is important to teach clients to maintain appropriate sodium intake and monitor TSH levels. When taking lithium, the patient should continue taking the medication on a regular basis, even when feeling well. The patient should not drive or operate dangerous machinery until lithium levels are stabilized. Notify the physician if vomiting or diarrhea occurs, and carry a card or other identification noting that he or she is taking lithium. Know about lithium toxicity manifestations. Please note that when clients experience symptoms like excessive urine output, mental confusion, severe diarrhea, or persistent nausea, it is usually time to notify the physician. Other symptoms include vomiting, ataxia, blurred vision, tinnitus, or increasing tremors. The physician should be notified immediately. Anticonvulsants. The most common anticonvulsants or mood stabilizers used for bipolar disorder include carbamazepine or Tegretol, valproate/valproic acid or Depakote, and lamotrigine, also known as Lamictal. Please recall a severe skin rash, an adverse effect of lamotrigine, which may turn into Stevens-Johnson syndrome. If you notice it, notify the provider immediately. All these medications should never be discontinued abruptly. Antipsychotics. Antipsychotics are not primarily used for bipolar disorder. However, they are used for symptoms such as delusions, mania, or hallucinations that occur during acute mania or severe depression. Some antipsychotics, such as olanzapine, aripiprazole, and ziprasidone, help with such symptoms for the long term. Antipsychotics should also not be discontinued abruptly. When using antipsychotics, the patient should use caution when driving or operating dangerous machinery. Refrain from discontinuing the drug abruptly after long-term use. Use sunblock lotion and wear protective clothing when spending time outdoors. Skin is more susceptible to sunburn, which can occur in as little as 30 minutes. Clients should report neuroleptic malignant syndrome or NMS. Here is a visual for NMS symptoms to be reported, including tremors, tachycardia, diaphoresis, agitation, diarrhea, hyperreflexia, and hypertension, among others. Other antipsychotic adverse effects, such as mental status changes, severe headache, tremors, skin yellowing, muscle weakness, malaise, pale stools, diaphoresis, sore throat, tachycardia, persistent vomiting, tremors, muscle rigidity, should also be reported. Consult the physician regarding smoking while on antipsychotic therapy. Smoking increases the metabolism of these drugs, requiring an adjustment in dosage to achieve a therapeutic effect. Avoid drinking alcohol while on antipsychotic therapy. These drugs potentiate each other's effects. Some bipolar clients may benefit from other treatment modalities, such as ECT and the bright light therapy. Please remember ECT is the last resort only if clients failed to respond to lithium or anticonvulsants. The light therapy, also known as phototherapy, may be beneficial in clients with bipolar depression, especially when depression tends to follow seasonal patterns like in seasonal affective disorder. Still, the mechanism of action for BLT is unclear. Outcomes for mania. We already mentioned the outcomes of bipolar disorder. Please note that patients and other people's safety is always a priority, followed by the disease's long-term maintenance strategies. They comprise no self-harm, redirection to reality, no hallucinations, good social rapport with other people, and adopting good sleeping habits. Thank you for reviewing the entire module 7 till the end. It is time to take the break you deserve. Good luck.